Thank you for that wonderful presentation. It's been a very comprehensive presentation of all the resections and lymph nodal dissections in the proximal and distal body tumors. So at this juncture, I would like to thank Vijay and his management here at Yashoda Hospitals for giving me this opportunity to speak. And on behalf of TASG also, as we think that a journey well started always sets the tone for successful, destination. And I wish and pray this should pave a way for the more future achievements for our organization. Thank you. So the debate regarding the extent of lymphadenectomy has been settled with the acceptance of D2 lymph node dissections being superior with the advent of chemo and radiation also. But however, the reconstruction methods are still being investigated with no single preferred method in doing the reconstructions. So this is one of the data where the present day trend of gastrectomies is being shown. This is from the data which is presented in 2023. We can see that there is a gradual increase in the number of proximal gastrectomies which are being performed because especially in the countries like Japan and Korea, where the early detection of early malignancies has in rise, and the gastrectomies, the trend in gastrectomies is progressing more to functional preserving and proximal gastrectomies for early gastric cancers. Now, if you see the various reconstruction procedures for doing a reconstruction after a proximal gastrectomy, we have esophagogastrostomy, jejunal interposition with a pouch, double-tract reconstruction, and sometimes also a tube-like stomach can be created for a esophagogastrostomy. Though the JCS guidelines recommend only 3 procedures, that is esophagogastrostomy, jejunal interposition, and double-tract reconstructions. Again, if you see the present day trend in type of reconstructions which are being performed worldwide, so this is again a data from Japan, Yamashita's publication 2023, where there is clearly again a trend in increasing trend in double-tract reconstructions and esophagogastrostomies being done more frequently than other procedures. Now, esophagogastrostomy is a very difficult procedure if not done, if to be done endoscopically, that is laparoscopically. But thanks to these newer devices called Orwell, which we can introduce through the mouth and then do the anastomosis intracorporeally with much ease. But the problem with the esophagogastrostomies is mainly the reflux symptoms, and along with that comes the complications like stenosis. So to address these problems, Adachi et al. In 1999 have suggested that a gastric tube technique can be performed along the longer the stem, lesser the reflux, bile reflux. So definitely the results of in terms of reflux are very good, but still has very high stenotic rates. So to address this again, Ann et al. Have suggested that instead of end-to-end esophagogastrostomy, a side-to-side esophagogastrostomy can be done using a linear stapler, and this has really decreased the stenosis rates by from 46% in an end-to-end anastomotic scenario to 0% almost. But the problem which remains is a severe reflux of gastric reflux, which can be addressed by few of these techniques which prevent the reflux. So these are mainly called flap techniques, which are proposed initially by Kamikawa, where with the help in laparoscopic setting, a hand-sewn technique was used, where 2 seromuscular flaps on either side of the stomach are raised and are sewn to prevent the reflux from happening over the anastomosis. So this has been a very good process, but it is criticized because it takes a long time for them to perform this procedure, and the outcomes are still very good. So a modification to this has been proposed by Mo et al. And in this, a circular stapler is used instead of hand-sewn anastomosis, and also the seromuscular cover flap is given only on one side, not on both sides, but on one side. So this is a modification which was proposed by Mo et al. And following that, again, recently in 2017 and 2022, Yamashita have proposed a side overlap fundoplication where a linear stapler is used to do the anastomosis, and also stomach is overlapped over the anastomotic site to create an artificial fundus. And also this also again helps in preventing reflux. So those are the few of the methods where the stomach is directly used for the anastomosis. Now we come to the second part where the reconstruction is done with small intestines. So as we already mentioned, the main procedures are double-tract reconstruction, jejunal pouch, and jejunal interposition.